Okay, well, we'd like to welcome you all to the 70th seminar in this Global Health History seminar series. The seminar today is on NGOs in the global health landscape. And we again have two speakers, one external speaker and one WHO speaker. Each speaker, which I'll introduce in a minute, will make their presentations, and then we'll open it up for questions both here in WHO and to our listeners who are assisting this seminar via the internet. So I just ask everyone to speak to the microphone so people who are listening via the internet can hear the presentations and any questions, and also to introduce yourselves so people know who is speaking. My name's Humon Moman, coordinator of WHO Press, and we'll now introduce the speakers for this session. So our first speaker is Dr. Michael Jennings. He's from the School of Oriental African Studies at the University of London, where he's senior lecturer in development studies. He has a background in development work, and he's also chair of the Africa group at the School of Oriental African Studies. And he will now give us the first presentation on some of the work that he's been done in this area. So, Dr. Jennings, please.
Oh, yes. Well, thank you, and thanks very much for inviting me to speak here. Actually, we're no longer, for those who know the institution, we're no longer the School of Oriental African Studies. We're now just SOAS, which apparently we've been told by branding and marketing experts is where we need to position ourselves. So we're now meaningless. I don't know whether that says anything about our education in the UK, but there you go. I pass no further comment. So what I'm going to talk about today is international NGOs, but I want to begin that by framing by saying that actually I think it's more important to think about the voluntary sector more widely. Now, when people talk about the voluntary sector or the third sector in relation to sub-Saharan Africa, they almost invariably mean NGOs. The types of organizations they're talking about are NGOs. They use the word voluntary actors and NGOs interchangeably, but actually they're not. And if you look at who is providing health services and health facilities across much of sub-Saharan Africa, just focusing on NGOs as service providers is actually very limiting. And it's also an important part of the narrative, as I'll go on to talk about, that we need to understand the voluntary sector more widely and how NGOs fit into that, because this explains some of the issues around healthcare by non-state, non-profit actors across sub-Saharan Africa. Now, the welfare landscape is characterized in sub-Saharan Africa by a very significant, perhaps not dominance, but certainly engagement by NGOs and other non-state, non-profit actors in healthcare delivery, and particularly since the late 1980s when we see the expansion of this sector. Now, this at least is the narrative, the traditional way of understanding it, that NGOs become dominant in the 1980s, and the critique of NGOs, the arguments about why some of the things that NGOs have been engaged in have perhaps undermined national health systems, stems from an analysis or an assumption that this myth of the rise of the NGO is right. But actually, as I'll go on to talk about, the voluntary sector participation in health and voluntary sector domination within health service provision is actually a creation of colonial empire, a creation that it exists by the time international NGOs come to exist. And this is important because it perhaps means that we have to look at the critique of NGOs and start questioning the extent to which it does reflect reality, and then moving on and saying, well, what actually is the role of NGOs? I mean, one thing we know is that the voluntary sector health providers do appear to be popular in much of sub-Saharan Africa, even when they are located next to a free state public hospital. Often NGO and other voluntary sector actor services provisions tend to be popular. Now, is that because, even though often they don't have the same level of equipment, they don't have the same level of staff, they may be quite seriously under-resourced, but nonetheless they do appear to be popular. Now why is this? Is this because they do something qualitatively different, which many of those who argue that we should be supporting NGO and voluntary sector service provision would suggest? Or perhaps is it because, as the critique suggests, that voluntary sector actors effectively crowded out other competitors? They started to dominate the sector, and therefore no other actor or other actors find it very difficult to break in and to challenge them. And I want to explore some of those ideas, albeit briefly, in this paper. Because actually I think both of those responses are accurate. Certainly, going back across the 20th century, voluntary provided hospitals and clinics and dispensaries have been popular. You can see that, even though they charge as against colonial state services, nonetheless they did prove popular. But I think there's also a level of truth about the notion that certain voluntary actors, in partnership with colonial and then post-colonial states, did serve to entrench their dominance and thereby push out other actors who might equally perhaps have become significant and equally popular providers. So I want to suggest that international NGOs are important and they play a role, but it's a role that is characterized by them entering into a particular form of health systems, in particular what is effectively a public-private partnership. The role they come into that already existing system, and therefore, rather than creating it, as their critics suggest, perhaps they exacerbate certain features rather than creating them anew. And I think a useful way of framing this is to borrow from the arguments of Jeff Wood, who talks about the creation of the franchise state. And he argues that from the late 1970s and particularly in the 1980s, what occurs, and he's writing about Bangladesh, but I think this applies equally to many developing countries, including sub-Saharan Africa, you start to get a turn away from support for state-run facilities. Donors and other organizations start effectively contracting out, franchising out a whole range of welfare services, be it primary health, be it education, and other forms of services. Linked into this notion that donors become increasingly suspicious of states, rather than being seen as the institution that should lead development, suddenly the state becomes seen as the major bloc. So the origins of new structural economics, structural adjustment, and the new policy agenda, and so on. And in the absence of other market-based private for-profit actors, NGOs and voluntary actors appear to be the logical choice. Who else are you going to get to run these kind of services? And so they are the ones who are given the contracts and effectively the parceling out the provision of services and the running of those services in many parts across sub-Saharan Africa. Now the result is that, or the argument is that as a result of the franchise state, services become fragmented. So you no longer have a national overview. Now everything is based upon the particular resources, vision, and so on of the particular provider, be it in a village or a district or however wide their area of jurisdiction is. And this also creates great problems of accountability, because no longer, if the state is not effectively in charge, how can accountability to the users be established and be ensured? And as a result, national health systems start to become weakened and start to become seriously undermined. So this is, although I think I have a great deal of sympathy with this argument, and I think the critique is quite powerful, I think the problem is that by focusing on this period of structural adjustment and what's going on in the 1980s, it misses the point that first services have already been franchised out. This is not something new. What's going on perhaps may be at an increased scale. It may be bringing in new actors, but it's not creating anything, I would argue, substantially new. And of course, different colonial traditions mean there are a slight different variants on that. So French-speaking Africa, Francophone Africa has a slightly different trajectory to Anglophone Africa, where and I suppose I'm mainly drawing on the example of British colonial Africa here. But I think it's important because this is where we start to look again at the role of NGOs. So by the late 1940s in Tanganyika, now Tanzania, effectively what you have in place is a health system that is a partnership between the colonial state and between voluntary actors. And in this case, the voluntary actors are all Christian mission hospitals, clinics. There are no other formal voluntary actors who are part of this formal partnership. There are other actors providing health, but they're not given a formal role in terms of funding, in terms of being able to contribute to policy debates, and so on. So in effect, the colonial state is admitting by this stage that it simply can't make any pretense to be providing healthcare for all Tanzanians unless it involves the missions, the voluntary sector in doing this. And under this model, the colonial state agrees to provide partial, limited financial support in order to turn these missions into contracted providers to the state. So under the terms of the various grants in aid regulations, the regulations that determine how and how much the state is going to contribute to these actors, missions would be expected to meet half the cost of the total grant from their own funds. And this, of course, meant it had to be externally funded because there was no way that they could meet those costs from the very low level of charges that they were charging for their services. So state financial support was predicated on the belief that voluntary actors would look to external sources. They would look outside to a range of donors in the 1940s and 1950s, often their home-based churches, in order to be able to provide the services they did, in order to pay for the clinics and the dispensaries. Interestingly, it's only the hospitals that are provided. The state grant does not provide for clinics. It does not provide for dispensaries. So in other words, although the voluntary sector health service provision is considered a formal part of the country's national health system, it's not supported fully. There is an expectation that those actors will look elsewhere for additional sources of income. And this is a pattern that is carried on in post-colonial Tanzania, so where the former missions are now joined by a variety of other faith-based actors, again, maintain their formal position within the national health system, but again, with limited financial support on the understanding they will look to a range of donors in order to pay for what ends up being the bulk of their services. And this system survives nationalisation. People often talk about Tanzania nationalising its welfare, which in theory it did. But in practice, voluntary mission hospitals and other voluntary hospitals and medical services were able to carry on running effectively as they had done. They continued to be in charge of their services under the same conditions as before. So the logic of this system was maintained. It was very difficult for a government to break, even a government as committed to nationalisation of welfare services as the Tanzanian government was, particularly from the 1970s. So the inevitable result is you have a large part of Tanzania's health system that can only function if it gets support from donors. That might be official donors, it might be other or international NGOs who are now starting to act as donors in their own right. But they can only function if they can get that level of support, which means that it relies entirely on the way that donors choose to fund or choose not to fund health services. And that exacerbates, it doesn't create vulnerabilities. Missions and then the later actors have always been vulnerable. But what the coming of the INGOs does, I think, is exacerbate some of these features, introduce increased vulnerability, particularly given the fact that international NGOs don't have the same kind of sustainable long-term relationships that missions had with their former churches back in their home countries. So it exacerbates some of these features. And this, in addition to exacerbating this state of precariousness, I think also worsens this issue of accountability, which I think is critical. It means it's much harder for organisations to be facing downwards when they're continually looking, almost on a day-to-day basis, for the next small round of funding that they might be able to secure from an increasing array of organisations. So there's little space for local voices. There's ultimately, I think, little concern for what the real health needs within the communities in which these organizations are working, because they don't have scope for that. They can only provide what they can get funding for. If that funding dries up, that service vanishes regardless of need. And so what I want to look at is the Longborough Maternal and Child Health Programme, not because it's particularly special, not because it's very significant, because I think it's entirely typical. It's a project that kind of vanishes. It's neither here nor there, but I think it's very typical of the way that voluntary actors and NGOs are interacting during this period, and some of the issues and tensions that this shows, that this illustrates. So this was run from Longborough Lutheran Hospital, so it's from a former mission hospital in southwest Tanzania. So for those who know Tanzania, it's kind of just a little bit to the east of Mbeya. It was funded by a number of international NGOs, including organisations like Christian Aid, like Oxfam, the two British NGOs, also Catholic Relief Services, who supported health projects and service delivery in the 60s, 70s and 1980s. And in the mid-1970s, they decided they wanted to establish a mobile maternal and child health clinic to go around to the villages, rather than just rely on the permanent clinic that they had in their hospital, to provide sort of the fairly standard maternal and child health services for those people who were unable or unwilling, perhaps, to come to the hospital. And the running costs were initially met for the first 3 or so years by Oxfam, who paid the salaries of 4 midwives, a driver, a clerk, as well as the running costs of the Land Rover. Catholic Relief Services gave additional support in the form of dried milk powder, cooking oil and other food-related inputs. But in 1978, Oxfam decided that they no longer want to focus their work in this geographical area, so they're moving elsewhere. So the result is that the Longborough is no longer part of their remit, part of their area in which they're going to devote their funding. So they signal their intention to start to draw down their funding and withdraw from the area. And Christian Aid is asked if it wants to take over support. So in 1978, Christian Aid gives a grant of £971, and then another just over £2,000 in 1979, and then a couple of years later it gives a further grant of £3,000. So what happens with the mobile clinics? Well, in 1978, when Christian Aid begin its relationship, about 10 villages are visited, and Christian Aid hopes this will be expanded to 16 villages within 2 years, and they also hope that in addition to the mobile clinics, they will establish 4 permanent clinics in village-based dispensaries. The progress is slower. By mid-1982 or early 1982, there's been a slight expansion, but it's only to 12 villages who are now being visited regularly by the monthly clinics. And 3 static clinics, permanent clinics, have been established within dispensaries, but each of them are only open 4 days every month. So it's on a fairly small-scale basis. And while the main clinic in the hospital continues to thrive, so something like 526 women giving birth in the clinic in 1982, the mobile clinic soon runs into difficulties. In mid-1982, a number of staff leave the hospital. Again, I'll come back to this. It's a perennial problem. These are expatriate staff whose contract and who decide they want to move on, or whose sending agency decide they should no longer be supported in that particular role. There's no new funding coming in, and the clinics, or the mobile clinics, are closed down. All of them are stopped. The doctor in charge, Dr. Elspeth Schmidt, asks Christian Aid if it will give a grant just to establish mobile clinics by foot, so those villages that they can reach by walking, but Christian Aid don't make a grant for that. So it's incredibly precarious. It's an example, and again, you could pick any kind of voluntary sector clinic, and most of them, many of them, particularly in these more rural areas, would look equally precarious, would have a similar experience of projects starting, expanding slightly whilst funding is available, and then collapsing or ending when that funding stream ends. But it couldn't sustain this mobile clinic that had been set up because it was seen as vital for the interests and the needs of pregnant women, new mothers and young children. It simply couldn't support the amount of resources, both financial and human capital, that this required. And in this is no real difference, not only from other voluntary actors going on at the time, but also if we've taken this story back to the 40s, back to the 30s, back to the 20s, exactly the same story. So NGOs didn't, or in this case, Christian Aid and Oxfam didn't create this vulnerability. They didn't create this precariousness. That already existed. But the ways in which they acted, I think, to some extent, exacerbated that, made things worse. So Oxfam's decision to move elsewhere and to withdraw funding meant that a mobile clinic was liable to be closed unless new funding could be found. And they were lucky. They found Christian Aid who were willing to fund it. But they only gave £971 as an initial grant. And yes, they backed that up with further grants and a later one to replace the Land Rover. But this was not long-term sustainable funding. This is one-off funding that had to be applied for separately every time. It wasn't saying we will support you for 5 years. Each time new funding was required, it had to be, the whole proposal process had to be gone through. It was subject to the normal kind of delays that Christian Aid, when allocating their funds, went through. It was competing with other proposals, both from within Tanzania and also from elsewhere. So, and as Oxfam shows, it was a commitment that could very easily be withdrawn. When Oxfam decided they were going to move elsewhere for their own internal logical reasons that made sense for Oxfam, that meant it could perhaps do things more deeply by focusing on fewer areas. But the result of that was to create great instability in this mobile health clinic. So it was very clearly the lack of financial resources, as Dr. Schmidt made clear, that led to the closure of the mobile clinics. By the middle of last year, our funds were used. Dr. Schmidt wrote to Christian Aid in 1983, because for 2 years we had to run the clinics without any help from outside, which caused quite a big deficit for our hospital. So the hospital was having to support these until it came to a point when it could no longer do so in the absence of any other money. Nevertheless, Dr. Schmidt concluded, she thanked them very much for their financial help. Presumably because she knew that she'd be needing to go back to them, because I'm not sure that Christian Aid really should have been thanked for their financial help. I don't think the money they gave, albeit Christian Aid having limited funds and needing to make decisions, but it wasn't necessarily given in a way that reflected the real needs or the real public health needs of those on the ground. And this state of precariousness goes beyond just the requirements for funding. So, for example, Tanzania is undergoing an economic crisis in the mid-1970s, early 80s. So there's a shortage of diesel. Diesel is both hard to get hold of, and when you can get hold of it, it's incredibly expensive, which meant that simply the hospital couldn't afford to provide mobile clinics of any kind, but nor could it fetch patients in emergencies to bring them to hospital. It couldn't transport building materials or make the regular dispensary visits. And even when diesel was available, the Land Rover, one of the 2 vehicles, was broken down. There was no funding to repair it, so essentially they only had 1 vehicle that had to be used for everything. The lack of kerosene meant that the kerosene-fueled fridges could only be lit the day before vaccination campaigns. So vaccines had to be taken whenever they were needed, from the hospital to where they were needed and then back again, because they simply couldn't be stored long term. The X-ray machine wasn't working because the power generator had broken down and there were no spare parts. There was no surgeon at the hospital, so they had to rely on periodic visits from a surgeon working at another voluntary sector hospital at some considerable distance. There was a single laboratory auxiliary who undertook over 6,000 specimen examinations during the year, alone without any other support. But despite this, Dr. Schmidt concluded in her annual report that this year was in many respects a satisfactory year for our hospital, and we are thankful that we can continue and consolidate our work without too big difficulties. Now, you read this catalogue of difficulties and you think, how on earth could you consider that to be a relatively successful year or a normal year? But that's because this is the reality. This is the way that these organisations are working. And not only is it about finances and about shortages and the availability of spare parts, these hospitals tended to be staffed by expatriate workers. which meant that, again, they could be very easily withdrawn. So in another hospital, for example, at Milo, the doctor was provided by the Voluntary Services Organisation from the UK. And when that contract ended, the only doctor for a 50-bedded hospital was withdrawn, taken away with no replacement. So essentially all the work that our hospital was doing, which required a doctor, simply could no longer be done. And going back to Longborough, when in the mid-1980s Christian Aid expressed an interest about perhaps restarting the mobile health clinics, they were told that Dr. Schmidt, the doctor in charge who originated this project, was no longer working, and we don't know when she's coming back, and we have no other one who is involved in this project. And the exact reason why she left wasn't known, but it was speculated on that it was the decision of her sending agency, that they had decided that she could best be used elsewhere. But to what extent could that decision be challenged by those who were making use of Dr. Schmidt, those people who were most directly, perhaps, and most seriously affected by her departure? And then the additional, and anyone who has read, by anyone who's worked for any donor agency, of course, but anyone who has kind of read the archives of NGOs, the perennial issue that keeps coming up is a demand for reports, and the complaint that reports aren't being written, which again I accept is NGOs and donors, if they are giving money, they do require funding. But we've seen this in the Paris Declaration proposals that endless requests from every single donor for reporting is a great burden on small programs. And this was the case here. So for that £971 that Christian Aid gave, they expected many regular reports, even after the term of that funding had ended. So probably only half joking, the Christian Aid project officer noted in relation to Dr. Schmidt, doubtless the doctor in charge is overworked relating to donor agencies as well as to her patients. So in a context where you have 1, 2, and very few medical practitioners, the additional burden of being expected to write reports, to write proposals, to justify every small amount, not just to one NGO, but to every NGO that was providing support or for whom support might be offered, became a tremendous burden. And I think this is where we come back to the issue of accountability. And I think this is the key point that Wood raises in his discussion of the franchise state. So the provision of these mobile clinics was clearly meeting an identified need. There was a belief that maternal mortality could be radically reduced by the provision of these services, that it would make a considerable contribution to maternal and to child health. But when that was withdrawn, what does that tell us about accountability? To whom could people complain? To whom could people address their concerns? They certainly couldn't address those concerns to the organisations that were providing funding, to Christian Aid, to Oxfam, Catholic Relief Services, and the other NGOs. And this, I think, is still a major problem for NGOs. That question of accountability is something that I think few NGOs have seriously addressed in a meaningful way. They couldn't really address those concerns to the state because this was not a state service. This was a franchise. This was run by a voluntary sector hospital. But how could they challenge the needs of that Lutheran hospital? If it didn't have the money to run those services, it didn't have the money to remove those services, to provide those services. So accountability in this sense meant accountability of the recipient to the donor, not to the community, and not to that of the international NGOs didn't have accountability to the services they were or for the services that they were subsidizing. And if rights are fundamental to well-being, if we think that accountability, that rights are important to strong, effective, efficient global governance for health and for strong health systems, then this, I think, is clearly a problem, an accountability that turned outwards and upwards rather than downwards. And I think this project demonstrates that NGOs didn't create the franchise state. They didn't create, as some of the critics suggest, they weren't necessarily complicit in creating many of these problems. But the way they worked inadvertently, certainly I'm not suggesting that this was deliberately done, but inadvertently by playing the role that they did, by working in the way that they did, and following their internal logic, rather than focusing on a different logic that might have emerged had they focused on the communities themselves, it exacerbated this inbuilt, inherent vulnerability, fragility, and precariousness that characterized voluntary sector healthcare provision. And I think drawing on this to perhaps think about some lessons for today. Well, firstly, clearly NGOs have questions to ask themselves about the way that they're engaging in health. But I think it's also incumbent upon international organizations, upon donors, to think again about how they are engaging with NGOs, to think about how they are putting in place measures and putting in place systems that mean the logics of international NGO and voluntary sector engagement don't exacerbate fragility and thereby worsen the experience of health and healthcare provision at the local level. Thank you.
Okay, so thanks to Dr. Jennings for his presentation. We'll now have the second presentation, which is by Dr. Daniel Lopez-Acuna, who is the advisor to the Director General and Acting Director of Partnerships. And so I'd ask him now to make his presentation, and then we'll open up for questions.
Thanks very much. Good afternoon to all of you. I'm going to be speaking about something that, yes, has a connection with NGOs, but it's very different to what we just heard at the beginning. I have to say that it was a very interesting presentation, and I would like to at least put on the table that it is very clear that we need to be discussing much more, especially vis-a-vis the goal of universal health coverage and the possibility of universal health coverage being one of the fundamental developmental goals in the post-2015 framework. What is the specific role that the non-state actors, and within that the voluntary sector, could play in advancing universal health coverage in some places? But also I just would like to say that it would be very interesting to compare how the evolution of this combination of the colonial state and the voluntary agencies happened in different colonial states, because the Portuguese, Spanish, or French have a very different evolution and composition of the solutions afterwards. So I think that's a topic for research that we will leave it there. Now I know I'm conscious of the time, so I'm going to share with you some of the developments that we are working on currently as part of the WHO reform in connection with the development of a new policy of engagement with NGOs. I can advance here, no? Yeah. Well, first, let me start by saying that the World Health Assembly last year requested the Director General to present a policy on WHO's engagement with non-governmental organizations at the board that took place in January. There was a paper and a presentation of issues to be considered in the formulation of this policy, and the board requested the Director General to keep working on this, but to link it with another policy development, that is the engagement with the private commercial entities. And they say, we would like to see, this is member states, a discussion of overarching principles for WHO engagement with non-state actors that may have different operational procedures for the civil society and for the private sector, but there has to be some common chapeau or umbrella of overarching principles. And this is being presented now to the board in May, after the assembly, and the document will be circulating in no more than a week. It will be posted in the web page of the board. And I would like to insist that this is not only a discussion in isolation, but it's part of the discussion on governance, specifically of the component of how do we engage with external stakeholders as part of the improvement of internal and external governance and the better positioning of WHO into the global governance process, global health governance process. Now, let me step back before we get into the policy and where we are going. And maybe in here we will have some more connection with the previous presentation, to elaborate in a very rapid way, in a nutshell, on some of the issues of the evolution of the NGO world or constellation of actors in the last, I would say, 50, 60 years. Because I think it's very important to understand how we engage with them, how they have evolved to define how we engage with them. I mean, the non-governmental organizations, as we know them today, actually came into existence in the second part of the 19th century. Now, the term that has been used to designate them originated actually after the creation of the UN. And I think we have to look at this in the larger perspective of the Cold War, of the UN creation, and of the several ideological constructs that are behind some names that we are now taking or using as if we were taking them for granted. But it's important to know that the provision was made in Article 71 of the Charter to give these organizations, the non-governmental organizations, consultative status within ECOSOC. And that was the first element of definition within the architecture of the UN. NGOs have been defined as any international organization which is not established by a governmental entity or international agreement. And there are now about 2,000 NGOs recognized by the process of accreditation with ECOSOC, including international, national, or subnational bodies. Of course, there is a myriad of NGOs that exist national at local level, but that not necessarily means that they are accredited or registered with ECOSOC. Now, the term NGO acquired throughout the years a much wider application, and is generally used to refer to various constituents. Certainly not only to the voluntary sector, and certainly not only to the public interest non-governmental organization. It encompasses exogenous and indigenous, voluntary, private, non-profit organizations engaging relief, rehabilitation, and development programs, but using finance that is raised either from voluntary, private sources, donor agencies, and that manage themselves autonomously at local, national, or international level. I mean, in a nutshell, it's a soup. It's a huge variety of entities that go from the fronts of industry to the public interest agencies to the professional associations. And we have to take that into account when we as an organization engage with these constituency defining broader groups. So, I mean, it includes charitable organizations, voluntary health agencies, foundations, grant-making institutions, social welfare organizations, professional associations, doctors, nurses, other health professionals, some chambers of commerce or business leagues or association of manufacturers or industry that is related to the health arena. And you just have to look at what is the list of our close to 200 NGOs in official relations with WHO to see that we have from the Association of Pharmaceutical Industries to associations of food industry to professional associations to public interest NGOs. So it's a much more complex issue than what it looks like. It's not just to open up to civil society. Of course, the bottom line is open up to civil society to widen their engagement and include it much more into the process of work of the organization. But we have to take into account this diversity of interest and to conduct then the necessary due diligence and filters to determine with whom we can and should be engaging and in which type of activity we should be engaged. I mean, certain types of organizations are also called voluntary organizations, development agencies, civil society organizations, membership organizations, advocacy organizations, grassroots organizations. We even talk today about movements or social movements that are under the umbrella of this larger component. Now, it's important to see that their growth took off after the Second World War. And there was about 90 NGOs that were founded each year since the creation of the United Nations, compared with about 10 that were created at the end of the 19th century. Now, after the Second World War, NGOs centered their efforts in relief work in crisis situations, flood, war, famine, but good part of the work was done at that time by faith-based organizations. And this is in many respects what the previous presentation was referring to. Now, in the 70s, NGOs started concentrating on sustainable development and sustained development, working through self-help groups on services provision at the field level. In the 80s, there was a much greater shift towards advocacy in the NGO world, trying to influence existing large institutions like us, WHO, and to work much more concentrated in developing countries, developing pro-poor strategies. Not exclusively, but I mean, there was an emergence of these currents. Since the 90s, and very much associated also with the end of the post-Cold War era, the NGO movement has shifted to a more catalytic role in people-centered development as a major trend. Now, in many respects, NGOs have emerged, and we go back to some of the points in the previous presentation, as in large extent to bridge the gap between governments and corporations that cannot do things in development that society needs. But a lot depends on the structure of the state, of the precariousness of the state, of the fiscal pressure of the state, and the institutional framework and development. So that's why generally we have a much greater proliferation of NGO entities providing healthcare in failed states, in weak health systems, and it's difficult to bring them on the same footing as a provider in terms of quality of care and in terms of the portfolio of benefits in many of the health systems of the world. But I have to mention that it's very important to mention this. WHO's constitution has a provision by the founding fathers and mothers of WHO that WHO should engage with other actors, not only member states, to advance the goals of the organization and the functions of the organization. But it makes a very important provision that we need to bear in mind, that when it is at national level, and you are dealing with national NGOs, this has to be done with the acquiescence of the national government that we are dealing with. It is not a direct relationship of WHO with national level NGOs. This refers much more to the framework of international relations with NGOs. So, I mean, yes, a huge number of NGOs play a major role in public health. If you see the delivery of healthcare, particularly in humanitarian situations, you will see either because of weakness of the state or because of the extraordinary amount of demand of healthcare that is created in these situations, that the majority of the healthcare is undertaken by NGOs, by non-state actors. And this is also a reality that we have to key into the equation in our relationships. Now, when we are moving in the direction of defining a new policy, what we want to do is to define the new policy of engagement of WHO understood at the Secretariat and the member states with NGOs, but without interfering in the sovereign decisions that take place at country level. This is the number one issue. Second, what we want is to leverage mutually beneficial cooperation, substantive cooperation at global, regional, and country level, and at country level with the acquiescence of the government, with a view towards improving public health outcomes, not just for the sake of the collaboration, but we need really to contribute to improve some of the public health outcomes and other public health outcomes of the organization. The NGOs have a critical role to play in supporting WHO to fulfill its constitutional mandate, and I would say even its general program of work. And they have been instrumental also in issues of advocacy for some causes of public health promoted by WHO. Now, where we are moving at, and I'm going to cut the presentation a bit short because of time, but I want to at least highlight where is it that we are going, is that the policy that we are trying to develop and get approved by the member states relies on a very clear set of overarching principles that also will be valid to other non-state actors. And the overarching principles have to do with four things. One, the supremacy of member states in the decision-making. No other actor that is not a member state will have the power of decision-making policy. They can be consulted, they can be heard, they can participate, whether they are NGOs or other non-state actors, even in our governance deliberations, but the decision-making is, the member states have the supremacy in the decision-making. Second, that we have to ring-fence, to shield, to protect as clearly as possible the evidence-based nature of the organization in the formulation of norms, standards, and policies. We cannot permit, neither from NGOs, nor from private sector, nor from any other entity, that vested interests come into interfering with the normative, objective science base. That doesn't mean not to talk to people, that doesn't mean not to collaborate in things that are not associated to the norms, but yes, we have to absolutely ring-fence the normative function. Third, we need to move into much greater transparency. And the idea, member states agree, is that we can have a total transparency of all interactions with all non-state actors that can be visible to the public and to the member state. And fourth, the fundamental issue of conflict of interest, where we cannot permit that the secondary interest prevails over the primary interest of achieving certain health outcomes agreed upon by member states, or interfere with the evidence-based objectivity of our normative function. But to this end, we need to further our existing practices of due diligence, of managing and assessing the conflict of interest that we will be associating with by interacting with not only NGOs, but particularly private commercial entities. Now, with respect to the NGOs, the rationale for all of this is NGOs are increasingly recognized as a central actor politically, socially, economically. They play a critical role in bridging the expression of health with policies in other sectors. They can help us a lot in the health in all policies as well. And there is a need for effective, sustained engagement, substantial as well, with NGOs to ensure much better governance around, among the myriad of factors that participate today in the global health architecture, in the regional health architecture, and in the architecture of health at national level. Now, I will conclude here. The presentation that I will make available has more details on this last part, but I don't have the time to go into that now. But where we are going is towards a policy that can, rather than just be centered as it is today in the designation of NGOs in official relations with WHO based on 3 years of work history with them, to move into a differentiated policy that has a component of consultation, a component of collaboration, and a component of accreditation. To delink the collaboration from the designation in official relations. And the reality is that more than 50% of the NGOs with whom we work are not in official relations with our region, just corporate. So, I mean, in a way, it's artificial to say that we only collaborate with those in official relations. And also make us ask the question, what's the point of the official designation of official relations? Second, to enhance consultation, regardless of whether or not there is an official relations status. We want to hear the views of all parties, of all perspectives, when we are embarking into policy formulation, and we need to move into a much more proactive consultative process. And finally, to enable participation in the governing bodies through an accreditation process that is not necessarily the official relations, and that can therefore not be conditioned on working relations, and can be more linked to the discussion of a certain issue or topic at the time that we discuss it with audiences. We are proposing a number of these issues to the member states. We have conducted web-based consultations recently in March with considerable input from the NGO sector, the private sector, the member states, and with all of these is that we are formulating this proposal of overarching principles to interact with non-state actors in the coming executive period. So I think I will stop here because I think that's the time limit, and thank you very much for your attention.
Okay, we've had two very interesting presentations on different aspects of work of NGOs, both with WHO and in the voluntary section. I'd now like to pass over to my collaborator, Professor Sanjoy Bhattacharya from the University of York, who will coordinate the question section. Thanks.
Thank you, Human, and thank you all for joining us today. If I could just reiterate the request that when you ask questions or make comments, could you please introduce yourself so that our colleagues who are on the WebEx system listening to us over the internet are able to recognize you if they know you, or get in touch with you perhaps in future if they find your comments or questions interesting. I'd just very quickly like to ask Dr. Acuna, who I thank for his wonderful presentation, where do you see the regional offices fitting in these consultations and the country offices? So as you negotiate with the countries, do they negotiate on the headquarters' behalf, or do you negotiate yourself directly and then empower these offices to act on your behalf? It wasn't clear to me. So I'd be very grateful for a clarification. Thank you.
Shall we wait for more questions?
Yes, yes. Are there more comments, sir?
Yes, please. My name's Richard Liang. I work in the Essential Medicines Program, and prior, many years ago, I worked in Zimbabwe in provincial health systems where 60% of the rural health services were provided by faith-based organizations. And since then, I've done a lot of work in East Africa. And it really comes back to the last two questions that Professor Jennings asked about what is the future role. And what hasn't been discussed is what has evolved for these church-based or faith-based organizations, particularly in East Africa. And what we've seen is an indigenization of these organizations and a cooperation where instead of it being all the individual churches having their own individual organizations, they have created church health associations. So in Zambia, the Church Health Association of Zambia sits on the Presidential Council for Public Health. 2 of the 5 members are mission-based organization or faith-based, both Zambians and both with direct access to the presidential office. In Kenya, MEDS, the Mission Essential Drugs Supply Organization, has an annual turnover of about $65 million. They're pre-qualified by WHO for their laboratory. Joint Medical Stores in Uganda is a major supplier to other NGOs, the MSFs of the world, and a lot of the medicines circulating in Eastern DRC are from these organizations. And so what we see now is that they are very autonomous, very influential, and somewhat self-sustaining. They have a group called EPN, Ecumenical Pharmaceutical Network, that coordinates all of these activities. And I attended their conference last year in Ethiopia, and it's very impressive just how much service delivery they are managing and how isolated they are from WHO, because of the point that Dr. Kuna makes, is that the national office does not have a mandate to relate to them. So the country office coordinates meetings of donors. All of the donors meet often on a monthly basis to coordinate their activities, and they communicate. The people not at that table are the ZACs and the national associations. And it seems to me a critical part of this evolution that what's happening here at the headquarters has to happen How it can happen at the regional office, I'm not sure, but at the national level, these faith-based, NGO-based coordinations at the national level have to find a way to interact at least at the same status as the donors who are coordinated by WHO in this way. And so I think we are going through interesting times. EPN, which represents these organizations as very effective pharmaceutical network, is not in official relations with WHO. They attend the assembly and the EB through the World Council of Churches. They're nominated by them. But that may stop. The World Council of Churches is talking about giving up its health program and not having anybody responsible for health. So I think as we evolve this relationship, these coordinating bodies, particularly of the faith-based organizations, are likely to become more and more important, and we need to find mechanisms to actively bring them in. I spoke to the people at EPN and said, why don't you apply for official relations? And they said, it's more trouble than it's worth. What are we going to get? The WRs won't talk to us, so if they won't talk to us, why should we be interested in collaborating with you? And for them, it's a critical obstacle.
Thank you, sir. Please.
Hi, thanks for these wonderful presentations. My name is Satya Chakan. I'm currently working as a consultant here with the nutrition department. Just 2 or 3 reflections and 1 or 2 interrelated questions. Looking at the earlier first presentation, and then looking at the way NGOs are involved in big time health delivery and health services, one question that is now I'm wondering is, what is an NGO's goal? I mean, it almost becomes, it's a philosophical, rhetorical position. We know that, for-profit companies work for profit. Our organizations like us, the UN, has got a certain mandate. So what exactly is an NGO's mandate in terms of how do they see themselves as growing? Growing in size, growing in number of projects? I think that is sort of going to define how things evolve. The second is, you mentioned universal health coverage. I think that is going to change the dynamics a bit. The other is the culture that is coming in now of cash transfers. With slowly things moving on to cash transfers, I mean, this is the question, how do you, both of you, see affecting the work of the NGOs? The other thing is, like, I feel when you spoke about norms, technical standards, etc., this is where there's a big problem in one sense. You see, I feel most of the NGOs, though the one big evolution has been the professionalization of NGOs and NGO work, which was sort of not quite mentioned or mentioned in different ways. They're becoming very technical and this and that. But one of the biggest contributions they bring is in the social sciences, not the so-called medical hard sciences. Now, when you take an organization like WHO, and I know this for sure because I've been part of it and seeing all the discussions, there's recognition, but simply not enough recognition, the amount of social science, how it affects and is important for technical strategies. The only serious major piece of work done is the social determinants of health stuff. So that if that space is opened up much more seriously as part of your norms and technical standards and what have you, we might see a much more engaged relationship. And of course, now we see Gavi, Global Fund, and all these. They've completely changed the nature of how NGOs operate. And we have to differentiate between these big NGOs who have chapters in countries and indigenous NGOs. All their roles are changing now, I guess. So less questions, but a few comments, I guess. Sorry.
Yeah, the role of regional offices and country offices. Oops, sorry. I mean, first, in the current system of designation in official relations, there is only one designation for WHO at large. This is not franchised by regions or by countries. It's not, let's say, fragmented or federated by regions or offices. But having said that, regional offices can engage NGOs in the regional committees, if so they wish, if they have a regional mandate. But that should not be a competing process with the global mandate. But that's, if you want, the bureaucratic process. I think the more important issue is some of the things that you were referring, particularly at country level. I very frankly would like to say we should go in the direction of being able to be a convener of all the relevant actors of health at country level, with dialogue and acquiescence with the national government at country level, but engaging NGOs, bilaterals, multilaterals, etc. I think our country offices and our WRs need to get out of the cocoon of only relating to the Ministry of Health. But it's not just a free ride. It has to be done within a framework, within the principles that govern the interaction with NGOs. But I think we need to be engaging those who need to be part of the dialogue. I think we are making some progresses. The current mechanisms of the country cooperation strategies contemplate the participation of NGOs in the discussions of the strategy of cooperation in medium term of WHO. But there is a much greater work that can be done. And that doesn't mean to bypass the sovereignty of the national government in convening the actors. And I think this is where we have to be extremely careful and delicate. We are not a supranational organization. We are an intergovernmental organization. We need to remember that. Now, just the second point I will make, and I will stop there. I agree with you on the professionalization of many NGOs in the recent years, and of the asset that is constituted in terms of knowledge. I think we need to simply treat this in the same way that we treat experts. They have to have no conflict of interest to participate in any process of normative nature. And again, we have to here deal with whether we are dealing with the individual or with the entity. We are dealing with the individual, we apply the same principles for individual conflict of interest. If we are dealing with the entities, we need to apply the organizational approach to conflict of interest. And we need to make sure that behind that great professional capacity, that there is no vested interest of whatever, either commercial nature or an industry that wants to go in a certain direction to deviate the normative function of WHO. So I think this is the way. I mean, bottom line, greater openness, but with clear framework to preserve what is fundamental for WHO. I think this is where we would like to go, and we hope member states agree on going in this direction.
Thank you. Some interesting questions there. To talk about faith-based organisations, and you're right, they're a key, if not the key. Well, they are in terms of sub-Saharan Africa. If you want to look at a development organisation, it's not NGOs, and I am distinguishing it. It's faith-based organisations. It always has been, and they've certainly expanded. So in the colonial period, it tended to be largely Christian for obvious reasons, not everywhere, but they have expanded. But in terms of these coordinating bodies, they themselves are not a particularly new phenomenon. In countries like Tanzania, the creation of the voluntary sector itself come about because missions move from kind of isolated, atomized individual organizations to creating coordinated bodies. Some of these actually end up becoming members of the WCC and engaging with states. Not necessarily autonomous, I can't speak for relations with WHO, but not necessarily autonomous from states. And this is where the creation of the voluntary sector is not just created by the colonial state, it's created by the faith-based coordinating bodies, who are, in doing that, excluding other actors. So I think one can distinguish between the formal voluntary sector, which in the colonial period means missions, and the informal voluntary sector, which is that sector which doesn't have access to state, doesn't have access to state funding, and is neglected. But they're clearly tremendously important. I think what's I mean, for a historian to say that faith-based organisations and religions are important is, we know that it's not important. What's become interesting is that from kind of the late 90s, donors in the World Bank became interested. DFID in the UK started to develop its own faith-based policy in the early 2000s. And so I think faith-based organisations have become seen as important because donors have recognised what they're doing. So it's donors who are scrabbling to kind of catch up and to see how to engage with them, because faith-based organisations have, especially now with so much international money, can survive. I mean, if you look at World Vision International, I mean, that in 2010, I think the money it spent was bigger than the total national aid budget of countries like Ireland, Portugal, and a few other countries. So they're important donors in their own right, but important to remember them. In terms, I mean, you asked a really good question about what is an NGO's goal, and it's a really interesting question. And I would say, and this is either going to sound simplistic or cynical, but I think their goal is to spend money and undertake projects. And I think that sounds simple, but actually it contains a large part of the problem, because it means that they always, so that shark, they always have to be moving in order to justify their existence. So, why are there so many NGOs involved in the health sector, which has been the biggest growth area over the past decade or so? And it's because the money is there. So NGOs that previously didn't do anything on health or did minimal work on health suddenly see a new pot of money and start to apply for it. And that may sound more cynical than the process is, but I think it's that logic of being needing to spend money, needing to run projects, creates problems. There's no kind of, you can't sit back and say, well, actually, we're not going to spend money, we're not going to run a project, we're going to close down. And you asked about cash transfers. I mean, I'm not sure how that's going to affect NGOs. NGOs themselves, I certainly can't speak for anything more than the very few that I've spoken to on this, see it both as an opportunity. So many of them are involved in cash transfers. But they also argue that the thing about cash transfers is that it's very good for individuals and households, but the kind of projects that many NGOs are involved in are those where just cash transfers are not sufficient. You need to have community-based responses. So it may be that NGOs increasingly see their role as focusing on community-based rather than individual. But my note of caution would be, for all the evidence that cash transfers are effective, every decade we have the new big thing. So will cash transfers be a permanent feature? Will they be the solution, or will they be something else that gets supplanted by whatever else the next big thing happens to be? And I think one thing I would say about NGOs is they've been very successful at sort of riding whatever wave happens to come along, evolving and shifting and taking advantage of new opportunities. And again, that may sound critical. I don't necessarily intend it to be as critical as that sounds.
Thank you. My name is Thomas Joseph. I work as the team leader for community engagement in the Stop TB department of WHO. And so my job is very much to engage with NGOs and other civil society organizations. I also have the dubious distinction of having worked with NGOs for 30 years and joining WHO when this new position was created last year. It's unfortunate that you do have a rather cynical view of NGOs. And I would think that the purpose of NGOs goes beyond getting money and spending it, and that really most of them have the simple objective of creating a better world, a fairer world, of people living in dignity, free from fear, free from want, and therefore basically trying to promote their fundamental human rights in some way or the other, either by providing services or by ensuring that government enacts legislation, or by being a watchdog to ensure that the private sector doesn't encroach on the human rights of peoples. Whether they do this well or not is, of course, debatable, and perhaps the cynicism stems from the fact that all NGOs are not as good as the other, and there are examples of bad NGOs as well. Just one comment on your presentation, Dr. Jennings, and one question to Dr. Lopez-Acuna. I think, you know, you lamented the lack of sustainability, and I'm wondering whether sustainability in service delivery is actually a good thing. You see, I don't believe that NGOs should substitute for the work of government. That's not, you know, the duty bearer of rights is the government. And if you as a citizen have a claim, then you must have an accountable duty bearer, which cannot be the NGO. So the NGO fills a gap in the absence of the government. It cannot substitute. So if it is closing down its services, it forces governments to ensure that those gaps that the NGOs have created are filled, because your rights are inviolable. You have to deliver those services. So perhaps actually NGOs should move away from service delivery gradually and go into other areas, as I said about human rights. Something to think about. And so it may not be such a bad thing. And Dr. Lopez-Acuna, I think this is really great that WHO is moving in this direction so formally and so steadfastly. I was wondering whether you can describe to us a little bit more about how actually these mechanisms will pan out. What do we intend doing to make this happen? How do we go about fostering collaboration? How do we enhance consultation? Are there some ideas and plans that you can share with us now?
Hello, my name is Anna Whelan. I'm advisor to the Director of Reproductive Health Research in the Cluster of Family of Women and Children. I've only been here 3 weeks, so I'm very interested to see lots of faces that I hopefully will meet. I guess I should almost declare a conflict of interest, because I've had a PhD student who has been studying faith-based NGOs, and she came up with a really interesting finding that I just want to share, which was that the faith-based NGO felt this enormous tension of the mission, which was how it was set up, which was the Christian mission of, you know, evangelizing, particularly in countries like Papua New Guinea, and then the addition of, well, actually the people really need health services, and so we will now provide those. And this particular faith-based organisation structurally split the two, so that the mission became a different arm, and the development projects and the getting of funds was done by another arm. Now that created enormous tensions within the organisation, because the people in the churches who were giving money into the boxes wanted to see the mission part, and the people who wanted to do good development wanted to see accountability, they wanted to see contracts being managed well. And in the meantime, AusAid was pouring money into faith-based organisations, because they were the only ones on the ground, only ones who had health workers, only ones that had facilities, and the faith-based organisations essentially carved up Papua New Guinea, so that the Catholics took one section, the Anglicans took another, the Lutherans took another. So it was the only way that the system was functioning, and I think that gets back to Dr. Lopez-Acuna's point about fragile states and where faith-based organisations and other NGOs have played a really critical role. The question is, what is it about the transition? How do you then get the state to take on this big challenge? It's enormous. It's, you know, you've already got so many actors playing in there. You know, really, I think critical thinking, and WHO has a really big role to play there, is how do we help facilitate that transition, because you've got donors who are also doing other things. So I think, to me, that's the interesting challenge. The other one that I've also been a regional director of an international NGO, and so that's my conflict of interest. I've now left that and I'm coming to WHO. That was an interesting period where you actually see the imperatives of what an international NGO, how they operate, how you work with the values system, which has to be up there, stated. You're not there making a profit, you're there to do certain things. And then the need to get the funds to do that. So I think it's a really interesting time for WHO to be engaged in this topic. There are also critics of WHO, like the People's Health Movement, who are saying you should be doing this with, you know, civil society. So I think how do we engage with all these actors and come up with a policy that I suppose assist states to deliver services and, as you say, provide the services that they should be.
Hello, my name is Dave Gray. I used to work in WHO, and I'm retired for quite some time. And I had the privilege of working with Daniel Lopez-Acuna also sometimes. I have a few comments and a few questions, perhaps. First of all, in response to the presentation, which was very interesting, of Dr. Jennings about Tanzania. Well, the two presentations were complementary. One was at the micro level, the other one was at the macro level, WHO. At the micro level, what stands out very, very clearly in Tanzania is the fact there seems to have, at least in the presentation, no effort made for this particular, let's say, mobile health clinics to have any relationship regarding sustainability with the government. That is, there was absolutely no effort made, it seems, I may be wrong, that someone would pick up the ball after they left. Now, if so, then it's a tremendous fault of the NGOs or whosoever it is. Second comment is regarding NGOs. I think I really tend to support it. There are thousands of NGOs, as you perhaps know in Gujarat, there are 30,000 NGOs. Now, the question is not they are good or bad or what they are there for, how to screen them. There is absolutely no system except only one in US I have seen of evaluation of NGOs towards certain objectives. There are brilliant NGOs. There are also absolutely self-serving NGOs. Just to quote an example, now WHO takes credit for this infant nutrition program. It was all started by an NGO. That's the NGO of the consumer group, which was in Malaysia. WHO was brought in kicking. Now it takes the credit, but that's fine, as long as the objective was fulfilled. So the evaluation is very important. Now I'll come to what Daniel had said. I can very well understand what he said because partly I was running the governing bodies for about 10 years. However, there is a major problem with WHO itself. International organizations have no accountability, explicit accountability in the governance structure. In a democracy, you have an opposition party, which always keeps the ruling party in place. There is an election of the party and so on. Here you have a Director General and or Secretary General in the US. Really, majority of the member states means majority of the people representing member states, they acquiesce with whatever is being said, and there is a little bit of give and take. So, for instance, I think from the time I was here, a lot has happened, this consultation process, the partnerships, and so on. But my question relates to so what? For instance, someone had said, a committee has been created, an Englishman, so that good ideas are put to the committee so that it's twisted and turned until it emerges as a toothless entity. Now, the consultation process you are saying, there is no guarantee it would be accountable, that it does take the advice into account, and there is no structure which looks at what is happening to it. And that's where I think we fail. If you remember, in the time of Mahler, there was this whole thing of optimal use of WHO's resources. He thought if WHO cannot do it, the evaluation, the member states collectively would be evaluating one another's performance. So in the regional committees, as well as here, he had set up a system whereby the use of WHO's resources could be evaluated and the member states would address themselves to this. In reality, it didn't work. They were all back slapping each other. So at the end of it, nothing, there was no evaluation whatsoever, and it was business as usual. And this comes to also, there are some people from India. For instance, if we are going to work with the state, the member state, look at the amount of corruption and the wastage of money. And there, the only work which is a bit honest and done by good NGOs. And how do you go around that process? Because it's a self-serving collaboration. So I'll stop at that.
Sure. No, thanks for the questions and the comments, and this helps to do the ping pong of the thinking process, I think. let me start with a few of the issues that you raised to go back to your specific question. You are absolutely right. The issue of the accountability in the governing bodies of the organization is a limited one because it's not a parliamentary democracy and there is no shadow cabinet or there is no, checks and balance system. I think the more we can aspire to is to have some ways of informal checks and balance at this moment. And I think that's good enough, frankly. It's better than nothing. I think some of these processes have started. I mean, I've been following very closely and I actually have been interacting a lot with People's Health Movement or with Democratizing for Global Health, the new coalition that was very much or is very much interested in WHO reform. And I think their observatory of the assembly and of the board and the reports that they disseminate are very useful. And I think it's useful not in terms of accountability of the Secretariat, it's in terms of the accountability of the member states to their people, because nobody creates a system of checks and balances for that. Now, from going from there to a structure that will incorporate more organically non-state actors in the governance, I think we are still far from it. What we've been discussing, and I'm touching upon one of the points that you made, is, for instance, instead of being reactive to the engagement of NGOs or to other non-state actors, be much more proactive and organize concerted hearings associated to critical policy developments of WHO. But hearings that are not only done by the Secretariat, but are chaired by the Executive Board or the Program Budget and Administration Committee, and say, well, we need to, if we are developing, just to, for the sake of the argument, a policy, an alcohol policy, and this is an issue that is very hot. Well, we have to hear lots of views of the good, of the bad, and of the very bad. Let's put it that way. That doesn't mean that they are going to interfere in the norm standard setting. But let's organize it and let's make it not as a favor or as a discretionary thing, but as a structure mechanism of gathering the views by even our governing bodies with the support of the Secretary. Something that has been on the table, but not all member states are in favor of this, is creating a, let's say, NGO or civil society mechanism. People have spoken about the Committee C in WHO. You may have heard of this. This has not progressed or not received the support of member states. Now, other organizations like FAO, for instance, have established the NGO forum or the NGO mechanism, deliberates on issues that are central to the organization, and then brings the deliberation to the governing bodies as a structured way of creating more platforms or spaces for consultation. This is going to be up to the member states to decide, but it's one of the ideas. Now, I think Deb already mentioned something that we also are trying to look into, and it's going to depend on how far member states want us to go. We need a good way of screening, of filtering, and this means conducting the due diligence to ensure that we are collaborating with entities that do not pose any conflict of interest. Sometimes they have the name of NGO, but that doesn't mean that they are not holders of vested interest. Now, part of the approach that we will follow, I didn't have much time to discuss it now, is that we should be looking at not only the type of entity that we interact with, but also the type of engagement that we will get into. It's not the same thing to consult than to collaborate, than to receive funds, that to engage, have them engage in our governance, that to be engaged in a governance of a multi-stakeholder partnership with NGOs, private sector, and UN entities. So I think, what we are proposing to member states is, let's have a framework that differentiates by type of engagement, that looks into the nature and characteristics of the entity, and that applies the overarching values. Now, this is complex, and I just want to put it on the table. We will not solve it just with, on the surface screening or due diligences. And this will have to be backed by member states, so the Secretariat has the appropriate resources. Not that we want to inflate it, but we need to do it properly. But I think the issue is, let's take the partnering with entities and NGOs included one step further beyond the bureaucratic and say, where is it that there is common ground? Where is it that there is common interest for public health goals? And then can we build it? Can we do it without conflicts of interest? Can we do it with transparency? Can we differentiate then the approaches? And maybe that even puts us a little beyond this, I would call it sometimes paralyzing debate between the idea of pingos and bingos, the public interest NGOs and the business interest NGOs. So I think we are trying to move in this direction with mechanisms, with instruments, but it will be depending a lot on the willingness of member states in this. Thanks.
Thanks. Yeah, you were talking about should NGOs move out of service provision and the idea that they're gap fillers, and I think it's worth pointing out that there are two versions of what NGOs are there for, and that's one version, which is that essentially they're there when it's to fill the gaps because the state isn't or can't do the things that it is supposed to do. But there's a rival version of that, which is that a well-functioning society is one in which private, both for-profit and not-for-profit providers undertake services. They provide hospitals, they provide education, and so on. And the problem, the problem for those who subscribe to the first is that the overwhelming dominance of certain international donors means within good governance agenda that the latter version is the one that's taken hold. NGOs are not seen and present. The reason you turn to voluntary actors is not because they're gap fillers, it's because the argument goes they are better at reaching the poor, they are better at understanding the needs of the poor, they are more representative, more participatory, all of which I think are not true. Well, they may be true for some, but I don't think it's true for the NGOs as a whole. I think the argument doesn't stack up. And it's just part of a market-based model. And if you look at many of the analyses that show why NGOs are more popular, quite a lot of that work is saying private health provision, private education provision is more popular, is better, but in the absence of for-profit providers, the best ones are to go for NGOs. So there are these two versions, and I think that's the, so the argument, should NGOs step back from service provision? Well, perhaps, but that isn't the way that momentum is going under good governance agenda. And it reflects these two versions. And I think this links into the point you were making, Dave, about sustainability. Why was there no effort? Well, the Tanzanian government would argue that it had built sustainability because it had franchised out. It said you are responsible for National Health Service in this area, so they didn't have to come and step in, and they wouldn't, and governments frequently don't. And I think this is, again, reflects back on these problems of the franchise state, because it then reflects to accountability. How do you ensure accountability in a model where accountability simply doesn't exist? And this, I suppose, would be my big criticism of NGOs. And I accept your point that their simple objective is creating a better world. Although you'd be hard pushed, I think, to find any, apart from maybe the arms trade. I'm pretty sure pretty much everyone says that's their objective, to make the world a better place. But good intention's not enough. And some NGOs have done incredible damage, and to simply say, well, yes, but they were trying to do good, to me is completely insufficient as a defence. And it's that lack of accountability is key. In order to be effective, in order to do the things that NGOs want to do, they have to be accountable, and I think there is a huge problem with accountability in terms of NGOs that hasn't been addressed, and some NGOs are working harder at addressing that than others, but nonetheless it is a fairly significant problem, and this is compounded by the way NGOs get used by international donors. In terms of the point you raised, Anna, about this split, I mean that's the problem, and that problem is often caused by donors who say we will fund your, in this case, medical or educational work, but we won't fund your evangelical work. So these organisations create these splits, but they're completely artificial. And the doctors feel, why would a doctor join a faith-based hospital rather than a public hospital? Because they often feel they've been motivated by their faith. and faith is such an important rationale for their work. There's a classic case of the Norwegian Lutheran Church, which has this split. So the Norwegian government funds their medical work, that makes it clear its organisationally completely separate. But then within the hospitals, they hold a prayer service. You don't have to take part, and it's not exclusionary. But how does that fit? You know, and donors are very wary of those things. And the problem is, it's political. And the reason donors have become more interested is because they were fairly comfortable supporting most Christian organisations. The problem was they didn't fund anyone other than Christian organisations. And they're very wary of funding, in particular, Islamic organisations. And that's where the real lack of understanding. So these splits, I think, are completely artificial, and they actually hinder understanding. Although they make it much harder to understand how faith-based organisations do, what are their particular areas of competitive advantage, and why donors need to take them seriously and engage with them, and move beyond this kind of fairly narrow political view. I mean, if you're looking at DFID, USAID, why do they want to fund more Islamic organisations? Well, it's not really because they think faith-based organisations do things differently or do things better. It's because they see it as part of their strategic and security interests to expanding it. But I mean, those splits exist, but I think you're right. It's tensions just mean it's nonsensical.
I think I'd like to thank the speakers for their time, wonderful presentations, all of you for coming here, the Wellcome Trust for continuing to support this program of seminars so generously, and all my WHO colleagues for putting in so much time and effort into these events. I mean, one thing that comes very clearly to me standing here, but also as a historian of global health for many years, and I know that the history of bureaucratic mechanisms can be very boring, but it is very important because it clarifies how health policy is actually implemented on the field, rather than what is planned in hallowed halls, in hallowed buildings. But the issue of auditing, I think, is something that is going to challenge you and your commission, because do we use the private sector, management consultancy companies? We know there have been big splits inside Gavi. Satya mentioned Gavi, about McKinsey coming in and MSF leaving in a half, or their reps leaving in a half. Or is this the historic opportunity for the WHO to become the world's auditors, rather than relying on the market? So the question is, how brave is the WHO going to be about this? And I'll end on those terms. Thank you.